Let's look at some AV blocks. We looked at that PR interval in the beginning and determined that anything above 0.20 would be a first-degree block. So that is a lengthened PR interval. We're going to look at a second-degree block, and we're going to talk about a third-degree block. So this is a first-degree block. You see that PR interval? It's prolonged. It's greater than 0.20. And there's no treatment indicated for this. This patient is pretty stable. But you do need to keep in mind that there is some kind of disease going on in the AV node because it is an abnormally long PR interval. So in your mind, you should be thinking, I should be avoiding AV nodal blockers in this patient. So this patient, you probably don't want to have them on beta blockers. And you really have to watch that PR interval because it can progress into other blocks. This is a first-degree block. Here we have a second-degree AV block. There's two different types. There's the Wenke block, which is the Mobitz type 1. This is where your PR interval gradually lengthens and then drops. It gets longer, nothing, then short. Longer, long. This one, not so concerning. Usually, no treatment is indicated. However, type 2 is a serious problem. And this can cause syncope because you actually are dropping. You see, normal, drop, normal. And this easily progresses into a third-degree block. So your PR interval is normal and constant, but then you're dropping QRSs. Okay, this easily can cause the patient to have a syncopal episode and again can progress into a third-degree block. These patients often require a pacemaker. And then we have complete heart block, which is your third-degree block. In third-degree heart block, you're going to see a complete dissociation between your atria and your ventricles. So if you were to map out your ventricle, your QRS complex, they will map out consistently. If you map out your P waves, they will map out consistently, but there is no association between the two. This requires immediate treatment. This also is usually will require a pacemaker, unless there's some kind of medication-induced reason that you can reverse. Now we're going to look at bundle branch blocks. So these are caused, this is that wide QRS complex, and this is usually caused by a block in conduction either on the right side or the left side of the bundle branches. So it's pretty easy to recognize bundle branch blocks once you realize there's a pattern to it. Again, it's all about patterns. So we're going to look on the next slide at the differences. We're going to see, what we're going to do is we're going to look at V1 and V2 in for both of these. Remember that it's considered a wide complex if the QRS is greater than 0.12. So we're going to look at V1 and V2. In a left bundle branch block, we're going to see a very wide QS. That's what we're going to see, a big QS. And in a right bundle branch block, we are going to see a R and then another R prime, and it's going to look almost like rabbit ears. So they have a very distinct, different look, and you will recognize it if you remember to look at V1 and V2. So let's take a look. Here on the left, you see normal conduction, V1 through V6. Now you see, look at your middle row, shows you the left bundle branch block. You see that? You have a QS, big and wide in V1 and V2. And then if you move to the final row, you're going to see your right bundle branch block. You see the rabbit ears that I was talking about? A very distinct look, very wide. Both of them are wide. So once you see that wide complex, then you look at V1 and V2 and you say, am I looking at a left bundle branch or a right bundle branch? And keep in mind, if your patient comes in and they have a new left bundle branch block, you need to send that patient, treat that patient as an MI, a STEMI, because it's really almost impossible to tell. So that patient should be treated as a STEMI. Here we have a patient who presents with a left bundle branch block, and you see why I say that could be a STEMI. It looks like ST elevations in the V leads, but it's a wide complex. So That's a left bundle branch block versus a right bundle branch block. And you see those rabbit ears in V1 and V2 that I was talking about. Left bundle branch block, much more serious. Last thing we're going to look at is infarctions, myocardial infarctions. And again, this comes from an occlusion of a coronary artery. We diagnose it with the 12-lead EKG, and that's where I was showing you that those cameras looking at different angles. The EKG is going to tell us which coronary artery is occluded. It's usually conceptualized in terms of the left ventricle, which uses the greatest blood supply. And we see this progress in a triad. We usually see ischemia, then we see injury, and then we see necrosis. So when we look at ischemia, we usually see T-wave inversion. When we see, when we see ST elevation or ST depressions, that's usually an indicator of cardiac muscle injury. And then when we see Q waves, that's a sign of necrosis. And we see that in somebody who has had a previous MI. You'll see the Q waves. So there's different types of MIs. These are the main ones that you see. It's not totally inclusive, but usually if we see ST elevations or ST changes in V1, V2, V3, and V4, we're looking at an anterior wall infarct. If you see changes, and you may want to go back to this EKG and look at those camera pictures or pull them up on a computer. If you're looking at 2, 3, and AVF, that's the bottom, that camera's looking up, that's an inferior infarct. And 1 in AVL is usually a lateral wall infarct. So you want to be looking for Q waves, you want to be looking for ST elevations, T wave inversions. These are all going to clue you in on what's going on with your patient, along with their history. So take a look at this EKG, and I'll give you a minute and see what you think is going on here. Sorry, I think I lost my place on my slide. Anyway, back to this EKG. I'm not sure how much time paused there, but if you look, we're looking at lead 1 and AVL, and you see the ST elevations there. You see how high that ST segment is off the baseline. So we're looking at a lateral wall MI, and you can see the reciprocal changes, which is common in some of the inferior leads. Look at lead 2, lead 3, AVF. You see the ST depressions there. This is a lateral wall MI. Here's an anterior wall MI. Look at your V leads, V1, V2, V3, V4, V5. You see the ST elevations there? And again, it almost looks wide, right? So that's why I was saying you never know. If you see a wide left bundle, treat it like an MI. So this is somebody with an anterior wall MI. And this one, if you look closely at 2, 3, and AVF, which are our inferior leads, remember 2, 3, and AVF, you see the elevations there. So this is an inferior wall MI. And this one I put up here because this one, if you look, you see some ST elevations pretty much everywhere. V1, V2, lead 1, lead 2, AVL, all the V leads. And this is a typical presentation of someone with pericarditis. And the treatment is very different for pericarditis than you're going to be giving nonsteroidals, anti-inflammatories. This can be some kind of viral syndrome. And just a few pearls to add. Really make sure you get a good history from your patient. The history will really guide your treatment plan. And remember your scope in the primary care settings. This is something I go over every semester, and if you've been in any of my classes, I've addressed it. It's really not appropriate to be drawing a troponin level in primary care. And why is that? Because if you suspect that this patient is having an MI and it warrants getting a lab value like a troponin, and you let that patient go home, you've really put yourself in a bad situation. If you feel that this patient is truly having a cardiac event, they need to be sent to the emergency room. Let the emergency room draw the troponin levels. You can get a 12-lead EKG. You can get your vitals. You can refer them to cardiology, whatever you need to do, but no troponin levels in primary care. So I think that's about it. There are other videos throughout this module that look at different aspects of the 12-lead EKG and the MI. I've tried to just include things that I think are useful. And then you have your case study to do, which is again another cardiac case study that looks at a patient who's having chest pain and presents to your primary care setting. Thank you very much.